You have been taking medication for years. Some of you take it every single day. And right now, at this exact moment, there is a reasonable chance that medication is attacking your red blood cells. Not as a side effect, not as a rare complication, as a predictable, documented biological reaction that your doctor never checked for because nobody ever ran a simple blood test that costs less than $30. That is not a conspiracy. That is the medical record, published in peer-reviewed journals, cited by the World Health Organization, confirmed in studies conducted across the United States, the United Kingdom, West Africa, and the Caribbean. And the people most affected by this gap are Black men over 35, specifically the ones who have no idea anything is wrong. Because most of the time, nothing feels wrong until it does. And when it does, it can feel like your body is shutting down from the inside. The condition is called glucose 6-phosphate dehydrogenase deficiency. You will hear it called G6PD deficiency. It is a genetic enzyme disorder that affects the red blood cells, and it is the most common enzyme deficiency on the entire planet. More than 400 million people worldwide carry it. And in Black men in the United States, the prevalence is between 10 and 14%. That is 1 in every 8 to 10 Black men walking around right now, going to work, taking their medications, eating certain foods, without knowing that their bodies have a vulnerability that, under the right trigger, can cause their red blood cells to collapse in on themselves at a rate the body cannot keep up with. This channel exists so that nobody in this community has to learn about this the hard way. Welcome to Marcus Webb, Black Health Truth. Today, I am going to walk you through what G6PD deficiency actually is, why it stays silent for so long, what breaks that silence and sets off a crisis inside your bloodstream, and most importantly, the one specific test you need to demand at your next appointment. We are also going to talk about something that almost nobody connects to G6PD, a diagnostic failure that is causing Black men to be told they do not have diabetes when their blood sugar says otherwise. By the time this video ends, you will understand exactly how to protect yourself and your family, and you will have the language to advocate for the test that could be the most important thing your doctor has never ordered. Here is what we are covering. First, we will break down what G6PD is in plain language, what it does inside the body, and what happens when you do not have enough of it. Second, we will go through the triggers, the common medications, the foods, and the infections that can flip a silent condition into a medical emergency. Third, we will cover the HbA1c problem, a diagnostic error that is hiding diabetes in Black men with G6PD deficiency, backed by research from 2 major biobank studies. Fourth, I will walk you through the test itself, what it is, how to ask for it, and what the result means. And fifth, we will talk about the genetic picture, how this gets passed through families, who else in your household needs to know about this, and why the X-linked pattern makes this almost exclusively a condition that is expressed in men, even when women in the family carry it silently. Let us start with the biology, because before you can protect yourself from something, you have to understand what it actually does. Every red blood cell in your body is under constant oxidative stress. Think about what a red blood cell does for a living. It carries oxygen. That means it is surrounded by oxygen molecules every second of every minute of every day of your life. Oxygen is essential, but it is also chemically reactive. Left unchecked, oxygen damages cells the same way it rusts iron. The body has multiple defense systems against this kind of damage. In red blood cells, the primary defense is an enzyme called glucose 6-phosphate dehydrogenase, G6PD. Its job is to produce a molecule called NADPH, nicotinamide adenine dinucleotide phosphate. Think of NADPH as the body's internal antioxidant currency. Without it, the red blood cell has no shield against oxidative damage. Without that shield, the cell membrane breaks down. The red blood cell ruptures. It dissolves before it can be replaced. That process is called hemolysis. Now here is the critical part that the standard medical appointment almost never explains. If you have G6PD deficiency, most of the time, hemolysis is not happening. Your enzyme levels are low, but under normal conditions, no infections, no triggering medications, no specific foods, Your red blood cells are living out their normal lifespan. You feel fine. Your blood count looks normal. Nothing on a routine panel would flag this. You would have no reason to know anything was wrong. That is why this condition has been called silent. Not because it is harmless, because it is invisible until something triggers it. Let me tell you about a man, 52 years old, lives in Atlanta, has managed his blood pressure for 6 years with medication that his doctor has adjusted multiple times. He also gets a urinary tract infection. His doctor prescribes nitrofurantoin, one of the most commonly dispensed antibiotics in the United States, with more than 4 million prescriptions given every year. He picks it up from the pharmacy without a second thought. He has taken it before. 3 days into the course, he wakes up feeling wrong in a way he cannot name. His urine is darker than it has ever been, like the color of dark tea. He is exhausted in a way that sleep does not touch. He is short of breath walking from the bedroom to the bathroom. He thought, I am just fighting this infection. Give it another day. But when he looked in the mirror, the whites of his eyes were yellow, and something in his gut said this is not the infection. He went to the emergency room. His hemoglobin had dropped sharply. His red blood cells were being destroyed faster than his bone marrow could produce new ones. A condition called hemolytic anemia. The cause was not the urinary tract infection. The cause was the antibiotic, because nobody had ever tested him for G6PD deficiency. And nitrofurantoin, for a man with that genetic profile, was not just ineffective, it was actively damaging his blood. That is not a dramatic edge case. That is the documented, published biological mechanism. And it happens because the medical system as it was designed, based primarily on research populations that underrepresented people of African descent, does not make G6PD testing a standard part of care for Black men. The World Health Organization recommends routine testing in any population where prevalence exceeds 5%. Among Black men in the United States, prevalence is between 10 and 14%. That is 2 to 3 times the WHO threshold. And routine testing still does not happen. That is not an individual doctor's failure. That is a systemic design failure. And I want to be clear about that distinction, because this audience knows the difference. Your doctor is not evil. Your doctor is working within a system that has never prioritized closing this gap. Understanding that difference is what allows you to do something useful with this information, instead of just getting angry about it. If you have a family member who has ever been told they had a mystery anemia, or who felt severely ill after starting a new antibiotic, or who recovered from a kidney infection only to need a blood transfusion that nobody ever fully explained, drop a comment below. Tell me what happened. Because this community is the database that the research is still catching up to. And when you share your story, you are doing something that matters. Now let us talk about the triggers, because this is the part of the conversation that can protect your life starting today. G6PD deficiency by itself does not cause a crisis. What causes a crisis is oxidative stress. Anything that creates a spike in oxidative stress in the body will overwhelm a red blood cell that does not have adequate G6PD enzyme activity. The most common triggers fall into 4 categories: medications, foods, infections, and metabolic stress. On medications, this is the category that carries the highest risk because medications are delivered deliberately and predictably. The drugs with the strongest evidence of triggering hemolysis in G6PD deficient individuals include primaquine, an anti-malarial medication, rasburicase, used in cancer treatment, dapsone, used for skin conditions, and nitrofurantoin, one of the most common antibiotics for urinary tract infections. Sulfonamide antibiotics, sold under brand names like Bactrim, also carry documented risk. High doses of aspirin have been associated with hemolysis in some G6PD deficient patients. There are over 140 documented compounds that carry some level of risk, categorized from high risk to medium to low. The complete list is maintained by the Clinical Pharmacogenetics Implementation Consortium and updated regularly. Let me say that again, over 140 compounds. And most G6PD deficient individuals have never been told to check a single one. On foods, fava beans, also called broad beans, are the most well-documented dietary trigger. This is where the term favism comes from. For someone with severe G6PD deficiency, eating fava beans can trigger a hemolytic crisis within hours. This is relevant not just for people in West Africa and the Mediterranean, where fava beans are dietary staples, but for anyone in the diaspora eating traditional foods from those regions. If fava beans are part of your cooking tradition and you do not know your G6PD status, this is a specific and practical risk. On infections, viral and bacterial infections independently trigger oxidative stress in the body. Even without any medication, a significant infection can initiate a hemolytic episode in someone with G6PD deficiency. This matters because the clinical picture becomes confusing. The person feels terrible, but so does everyone who has that infection. The anemia may be attributed to the illness itself rather than to an underlying G6PD-mediated breakdown. The diagnosis is missed again. On metabolic stress, research has shown that diabetic ketoacidosis, a serious complication of uncontrolled diabetes, can trigger hemolysis in G6PD deficient individuals. Which brings us to the connection that almost nobody in standard medical practice is talking about yet, even though the data has been published. If you are Black, male, over 40, and your doctor uses a hemoglobin A1C test to check your blood sugar, which is the standard of care, I need you to hear this next part very carefully, because what I am about to explain changes everything about how your diabetes risk has been assessed. Hemoglobin A1C, written as HbA1c, is the most common blood test used to diagnose diabetes and prediabetes. It measures how much glucose has attached to your hemoglobin over the past 2 to 3 months. The higher the reading, the more your blood sugar has been elevated over that period. A reading of 6.5% or higher is diagnostic for diabetes. A reading between 5.7 and 6.4 is considered pre-diabetic. Here is what G6PD deficiency does to that number. Because G6PD deficient red blood cells have a shorter lifespan, they are being destroyed faster. They have less time to accumulate glucose on their surface. The HbA1c reading comes back artificially low, not because your blood sugar is under control, because your red blood cells are being recycled too fast to absorb a normal amount of glucose. So you can have genuinely elevated blood sugar and receive an HbA1c reading that says you are fine. A major study published in Diabetes Care using data from the UK Biobank found that G6PD deficient Black men had average HbA1c readings that were nearly 1 full percentage point lower than non-carriers, even at the same blood glucose levels. The same study found that G6PD deficient men were diagnosed with type 2 diabetes an average of 4.1 years later than non-carriers. A 4-year delay in a disease that causes progressive, irreversible damage to the kidneys, the eyes, the nerves, and the cardiovascular system during every one of those 4 years. Think about what that means. You go to your doctor. You are concerned about your blood sugar. Your doctor runs the standard panel. Your HbA1c comes back at 5.9. Your doctor says, borderline, let's watch it. Maybe suggest some dietary changes. You leave relieved. But your actual glucose levels, if tested directly by fasting glucose or a glucose tolerance test, would tell a different story. Because the HbA1c number, the one your care is based on, was being suppressed by a genetic condition nobody ever tested you for. Now I know what some of you are thinking right now. My doctor is good. She knows my history. She would catch something like this. And I understand why you feel that way. But here is what I want you to understand about why this keeps happening even with good doctors. Routine newborn screening for G6PD does not happen universally in the United States. Routine adult screening does not happen at all in most clinical settings, even in populations where the World Health Organization explicitly recommends it. That means your doctor cannot catch what they do not test for. The gap is not in the clinical relationship. The gap is in the screening protocol. And that protocol was designed without this community's biology at the center. If someone in your life, a father, a brother, an uncle, someone you love, has been told their diabetes is well controlled but continues to have complications that do not match the HbA1c number, I want you to think about this conversation right now. And if you want to go deeper on this specific topic, the ways that standard diagnostic tests underperform for our biology, subscribe and turn on notifications. Because the work we do on this channel is exactly about closing that gap with information, not speculation. Let us talk about the genetics, because this is the piece that makes G6PD deficiency so specific to the male experience, and so relevant to the women in your life who are carrying it. G6PD deficiency is what is called an X-linked recessive disorder. The gene that codes for the G6PD enzyme sits on the X chromosome. Men have one X chromosome and one Y chromosome. Women have two X chromosomes. This single difference changes everything about how the condition is expressed. When a man inherits a defective G6PD gene on his one X chromosome, he is what geneticists call homozygous. There is no second copy to compensate. He expresses the full deficiency. He is the one who develops symptoms when exposed to triggers. He is the one who ends up in the emergency room. A woman who inherits one defective copy and one normal copy is a carrier. She may have reduced enzyme activity. Some carriers do experience mild hemolysis under significant oxidative stress, but she is far less likely to develop the full clinical picture. The critical piece here is that she can pass the defective gene to her children. Her sons who inherit it will be affected. Her daughters who inherit it may become carriers themselves. This means that if you are a black man with G6PD deficiency, at minimum, your mother is a carrier. Any sisters you have may be carriers. Any daughters you have will be carriers. Any sons born to your daughters could be affected. This is a family conversation, not just a personal one, and it starts with you getting tested. The test is called the G6PD enzyme activity test. It is a quantitative blood test. It measures the actual enzyme activity in your red blood cells, expressed as units per gram of hemoglobin. The fluorescent spot test is a qualitative screening version that is faster and less expensive, though it is less precise and can miss heterozygous women. For men, the quantitative assay is definitive. One blood draw, results within days. The test is available at virtually any standard clinical laboratory in the United States, the United Kingdom, Canada, and across the African continent at major medical centers. There is one timing consideration I want to be clear about, because this is where false negatives happen. If you test during or immediately after a hemolytic episode, the test can come back falsely normal. This happens because the youngest red blood cells, the ones the bone marrow just produced to replace what was destroyed, have higher enzyme activity than older cells. When older cells have been eliminated by hemolysis, the ones left are the young ones, and they make the reading look better than it actually is. This is documented in the clinical literature. If you have recently had an infection, a hemolytic episode, or a significant illness, tell your doctor and ask to wait 6 to 8 weeks before testing to get an accurate baseline result. What do you say to your doctor? You say this: I would like to be tested for G6PD enzyme deficiency. Based on my ancestry and the published prevalence data for black men in this population, my risk is between 10 and 14%. I would like a quantitative G6PD enzyme activity test added to my next blood panel. That is it. That is the conversation. If your doctor is unfamiliar with the test, you can reference the World Health Organization guidelines on G6PD testing, which explicitly recommend routine testing in populations with prevalence above 5%. You have the right to that test. You have the scientific basis to request it. And now you have the language to do it. The management of G6PD deficiency is primarily about awareness. There is no medication required. There is no daily treatment. The goal is to know your status so that every future medical decision is made with that information on the table. It means your pharmacist knows to check the G6PD risk profile of every new prescription before filling it. It means your emergency room chart carries the notation. It means that if you are ever hospitalized and a provider reaches for nitrofurantoin or dapsone or a sulfonamide, someone in the room can say, "Stop, check his G6PD status first." It also means your blood sugar is being assessed with the right tools. If you have G6PD deficiency, a fasting plasma glucose test or an oral glucose tolerance test gives a more accurate picture of your metabolic health than HbA1c alone. That is the specific conversation to have with your doctor. Given my G6PD status, can we add a fasting glucose test to the standard diabetes screening protocol? That one question could catch a diagnosis that might otherwise be delayed by 4 years. When you understand your own biology at this level, you stop being a passive recipient of whatever the system offers. You become your own advocate in the room. And that advocacy is not confrontational. It is informed. It is specific. It is backed by research. And it is the most powerful thing you can bring to any medical encounter anywhere in the world. Here is the challenge I want to leave you with. For the next 7 days, I want you to do one of the following. If you have never been tested for G6PD deficiency, schedule a primary care appointment this week and request the test. If you already know you are G6PD deficient, pull out every medication you are currently taking and verify it against the G6PD risk list published by the Clinical Pharmacogenetics Implementation Consortium. You can find it online. It is free and publicly accessible. If you have a family member, a brother, a son, a father who has never been tested, share this video with them today and have the conversation this week. And when you go to your next appointment, bring this question. Given my ancestry and the published prevalence data, should I be screened for G6PD deficiency? And if you have G6PD deficiency and you are being monitored for blood sugar, ask your doctor to add fasting plasma glucose to your testing protocol alongside HbA1c. Your body has been operating with a genetic vulnerability that the medical system was not designed to catch. That is not your fault. That is history. But what happens next? The test you request, the conversation you start, the information you share with your family. That is yours. The biology does not change. What changes is how well you understand it. And understanding it at this level is already an act of protection. If what I just walked you through gave you something real, something you are going to use, something you are going to share with someone you love, then please like this video, subscribe to this channel, and make sure the notification bell is on. Because every week, this community is building the kind of health literacy that our ancestors were actively denied access to. And when you subscribe, you are saying that your biology matters, your history matters, and the science that explains both of them matters. We will see you in the next one.